Hi, I'm Jim. I work with Joint Operations. Welcome this afternoon to today's Joint Operations e-learning session in collaboration with Clockwork Medical. We're delighted today to welcome Professor Martyn Snow, one of the world's leading experts in cartilage management. Martyn's going to talk us through his experience and knowledge around cartilage repair, looking at what an algorithm would look like in a perfect world scenario. So if all technologies are available, price wasn't an issue, and so forth. But also what that algorithm looks like in the real world. So in everybody's hands, what can you do and when and how and why. We're also delighted to have our good friend Christian Besnar on the line, JRF's Executive Director. Christian has extensive experience in the allograft world, and he's going to be able to talk us through a little bit about that delicate process of taking the allograft from the donor stage through that process, and then how that ends up in the hands like surgeons like yourself or Professor Martyn Snow. So without any further ado, I will gladly hand over to Martyn, and I hope everyone enjoys the show. Thanks.
Okay, so first I thought we'd discuss treatment of cartilage lesions greater than 2 square centimeters. Basically, this is the easier category, I think. But I thought at first I'd put some background on it because I think it becomes a little bit relevant later. So depending on which source you read, somewhere in the region of 10 to 16,000 people undergo a cartilage repair treatment in the UK each year. And NICE in their figures estimated that based on their criteria, 500 of these should be a ACI each year. And this was probably a slight underestimation because of the selection criteria that they impose, which we'll discuss. So it probably should be more than 500 a year. Like I said, the big lesions are the easiest and less controversial because we do have some guidelines for these. So it comes a little bit more relevant later, but in terms of the literature, I just wanted to put it into context. Just need to think about these factors when interpreting it. The literature is not really representative of our daily practice. I estimate it's probably somewhere between 5% of people that you see with cartilage lesion are suitable for a clinical trial. So that's a large part of your practice which isn't suitable and not represented by the data and literature. All treatments are essentially the same at 2 years in normal people. So what I mean by that is non-athletes, and consequently it's the long-term follow-up which is important to sort of read into, which unfortunately is the weakest part of the literature. Cartilage trials are very expensive. They're often, as a consequence, low in numbers because of the time it takes to get those people, because they only represent 5% of your practice. And in reality, if you're going to have a study comparing 2 treatments, the power needs to be around, or the numbers to give it power need to be around about 100. So just bear that in mind, again, when interpreting the literature. But as a consequence of this expense, it's limited to high-value products such as ACI. And when we get down into scaffolds, which are less or cheaper, it still takes the same amount of money, roughly, to carry out the trial. So consequently, it's harder for these small companies to do that. Surgeon experience is therefore limited by early failures, because it's pretty rare for us to see any of these patients beyond 2 years unless they get sent back to us, but because of the young mobile population, they may not. And therefore, decision with regards to the smaller treatments should be based on a balance of evidence from the animal, human data, economic, regulatory restrictions, so practicalities of actually obtaining the product, and then sort of personal preference in implementing it. So those things are just sort of bear in mind. But just like any other cartilage talk, really, the knee is an organ. You know, you can't think about cartilage repair unless these factors are in place. So the alignment, the meniscus, and if you haven't got a meniscus, then meniscus transplant should be considered. And 50% is the sort of agreed mark. So if you have less than 50%, then a meniscus transplant should be considered. And ACL reconstruction, obviously, which is the most common form of instability. With regards to alignment, we should be pretty aggressive, I think. And for me, if your mechanical axis is outside of the tips of the tibial spine, then that would be an indication for an associated osteotomy. So it's pretty aggressive, but I think we need to be given that our treatments are not ideal at present. So moving on to ACI initially, eligible lesions are those greater than 2 square centimeters, no previous history of cartilage repair, no osteoarthritis, and they clarified that it has to be within the knee. So they didn't say femoral condyle, so theoretically you could still do patella. So I did some quick maths, not complete. So, 31 months since NICE approved ACI, and these on the right are the NHS England centres which are said to be designated. It's not complete. For example, there's still no centre in the Northwest. So, but they are some of the centres that are supposed to be doing it. So we did some quick maths. So in 31 months, our time we set up with codon, it's 30 cases. Robert Jones, Oswestry, they've obviously carried on through Ozcell, so they're self-manufacture. So it's somewhere between sort of 50 and 60 cases in that time period. Exeter, I wasn't able to get the details before this, but I'm not sure how many, but he certainly won't be doing more than Oswestry. Sheffield's done 1 case, Southampton 1 case. So, you know, best case scenario there, we're probably looking at about 120 cases in that time period based on NICE figures. We should have done 1,250 ACI cases in that period. So there's a significant unmet need in the UK, and that has implications. If we look at codon, which is the only commercial product available in the UK, so in Germany they've done 14,500 cases, which is a phenomenal number. Austria have just started, Netherlands just started, and then Italy and France are going to come along with the UK. If you try and look at the evidence for codon, it's actually a little bit limited. So they did this dosing study on the left here to look at which or how many chondrocytes per square centimeter is beneficial, and then they did this study where they compared adolescents to young adults. And actually, the study that they used in the NICE evidence is actually unpublished, but it's basically based on 102 patients, which is so appropriate power, and that's the sort of power that you need. Which is power to show non-inferiority to microfracture with 2-year follow-up. But like I said, it's not published. We don't really know what the data are, but I believe it did show non-inferiority. So there's some advantages to the current product. So this is on the left here. So these yellow dots are spheroids. There's about 200,000 chondrocytes per yellow dot. And this is a lesion of the trochleus. It can be inserted arthroscopically. That brings its own technical challenges, but after 20 minutes, they do become stable so that it can stick on the surface and you can introduce water in at that time period. It takes a little bit of confidence to get to that stage, but it is actually possible to do that. But it's an unusual product, which does take some getting used to. In terms of the practicalities of performing ACI, so the limitations are in place because you need a HCA license, which is a big challenge for a lot of places now. We've given them all up and then they're taking SLAs with allograft companies. So, and this is not easy to get back once you've lost it, as there's a significant administrative and financial cost to that. Once you have that in place and you've developed your SOPs, various risk analysis, then before doing a case you have to have an MDT to discuss that case, make sure it meets the criteria. Then you have to order it on a blue tech system, which is this high value pharmacological program which the rheumatologists commonly use to order these expensive drugs, but it just creates an audit trail with your signature on the bottom essentially. You have to follow, you have to undertake a specific consent process outside of the normal consent, which is codon consent, as well as undertake a HDLV1 sample, which is a blood test you would normally get if you go for organ donation or blood donation. And all this needs to be documented in the notes. There's some issues about pediatric patients. We can't do patients, the product's not licensed for people over the age of 18. And so if I have a pediatric patient that needs treatment, then I refer to Oswestry because they can do under 18s. Is inability to control dosing. So here, this is the product going in, where the little yellow balls you can see, spheroids, are being inserted, but it's on this stylet, and it's very difficult to actually control that stylet if you have more than one lesion. Like I said, dry scope comes with some difficulties. And yeah, to start with, it's very different to what we used to. We don't have a patch, can't structurally sew it in, and consequently, in uncontained lesions, it's going to take a bit of getting used to. So in terms of osteochondral allograft, this is the other potential treatment for lesions greater than 2 square centimeters. So the strengths of this are bone fixation, hyaline cartilage immediately, and we're not size limiting. So, unlike autologous version, we can go as big as we want, really. So fresh allograft, so then there go strict protocols of screening and testing to reduce the risk of disease transmission. Following harvest and 24 hours of treatment and antibiotic solution, the grafts are then refrigerated at 4 degrees in either ringers or in a culture medium to maintain the viability. And so it's a minimum 14 days before they're released, and it takes this long to get the bacterial swab results back, as well as the various blood tests back from the donor. And then you need to size match it to the donor. So it's not a case of just simply taking any graft, it must be matched. So it's particularly the bigger you go, the more important it is to size match the condyle so that you can get the same radius of curvature, whether you're doing a shell allograft or a mega oats. And there's been even more restrictions now placed on the HTA in terms of how these grafts are processed. So this has an impact even further now on availability in the UK. And it's all about cell viability. So although the data on this is actually a little bit fuzzy, but it's believed that there's an inverse relationship between storage time and chondrocyte viability, but it's all done in dogs, really. And so in the dog model, it was shown that results were better if the viability was above 70%. But actually, if you look at the human samples, we seem to struggle to keep viability above this, even in the current protocols. So the current recommendation is to actually get these grafts in as soon as possible to maintain this viability, but the official sort of sell-by date is 28 days. In terms of indications, so technically in the States, it is an osteochondral lesion or chondral lesion greater than 2 square centimeters, but it's much more widely available in the States. And I think really for us, it should be refined a little bit more and to keep it to the people that really need it. So large traumatic lesions, large osteochondritis dissecans, AVN, and revision procedures, because there's not a lot of options in this group, as opposed to ACI is open to people in the greater than 2 centimeters group. So if you can have ACI, you should have ACI, and if you need osteochondral allograft, then we should be able to do that. So just to run through a couple of examples and demonstrate the technique. So this is multiple AVN due to chemotherapy, probably 4 minutes. So that's the scope, just the whole condo is dead, really, and the cartilage is coming away. I think the important thing is that on the opposite side, you can see here there's an infarct there, but it doesn't go into the subchondral bone, so there is a gap, and these tend to be asymptomatic. Similarly on the tibia there, as long as you've got a normal piece of bone, then they're okay, but obviously on this side it's gone in and it's collapsed. So that, osteochondral allograft really is the only option here. ACI, you have to bone graft all this, and we know the results are worse in that sort of sandwich technique. So this one was suitable for a mega oats. So she had 2 dowels cut from the hemicondyle, which was sized to her, and we try and keep them as low as possible. So 5 mils of bone would be the max ideally, but in someone like her that needs more, you can then either graft with autologous, or you can extend up to 10 mils to replace all that dead bone. But and this is her 18 months later, so you can see it's integrated well. We've got rid of that infarct, and we've matched the joint surface. Not too bad, but even then the radius of curvature isn't quite right. And then in terms of massive OCD, so this is a 17-year-old. This isn't a cut through the notch. This is actually a CT of the femoral condyle. It's missing. And this is one of these sort of almost congenital type OCDs that we see. And this has to be done by a shell technique, where you actually just cut a large piece of the condyle off and then hand shape it to match him. And then, as you can see, trying to keep it as thin as possible, but there's limitations because it can be quite tricky just to shape this by hand. And then this one needed an osteotomy, which I actually did 6 weeks later, because he's non-weight bearing for 3 months, and then did that 6 weeks later before he started weight bearing, so that it just reduced the operative time in one session. And then failed cartilage procedures. So the classic one would be microfracture. So, and we'll talk about this a little bit later, but this large interlesional osteophyte from previous failed microfracture, which again, 2 dowels, and this really is the only technique which has been shown to be as good in a revision situation as opposed to a primary situation. So that, again, we should reserve osteochondral allograft for this sort of scenario. And the issue around osteochondral allograft is not only availability, but it's also funding. So for me, it's originally been a individual funding request, but that's actually become even harder now. So we're having to look at a new service development. For others, they're using it or coding it as a bespoke implant and getting around the funding that way. With the insurance companies, and it's very much a case-by-case basis. So saying, well, these are suitable for ACI, but we do this because it's better and it's roughly the same price, so they'll often maybe consider authorising that, because the hemicondyles are approximately £13,000 or £14,000, I think it is now, and ACI is £10,000, but it's 2 surgeries, so it sort of equates to roughly the same. And our problem when you come to actually, if you have to speak to someone in the CCG or whatever, there is no tariff, there is no NICE guidelines, and therefore they do not compute really. It gets very difficult to try and explain it. And if we look at cost effectiveness, we know from the Warwick evidence group who did the ACI work, they compared osteochondral allograft to natural history, showed it to be highly cost effective, and also said that revision OCA also appears to be cost effective, although the evidence was a little bit shaky. More evidence is needed, but it's a cost effective procedure against natural history, and we've sort of tried to compare it against ACI. So these are the data for ACI and OCA. And if we look here, so OCA, there's a lot of data out to 15 and 15 plus years with excellent survival. So 66% of 20 years there. And if we look at ACI, again, we do have data out to 15 years, 71%, again, good data and comparative results really, but there's a lot less actually in the ACI than there is in the OCA group. And the problem is we're never going to be able to do a trial comparing these 2 treatments. So it's very much sort of, I think, not saying they're interchangeable, but to say that OCA is for bone and cartilage loss or revision, ACI is for chondral loss, with some bone can be compensated, but it's very much a chondral treatment. And if you look at, if we compare the cost of ACI versus OCA, so we've got the 1 surgery versus 2. Graft survival is good in both. Quality repair is good in both. We've got complication rates the same. Return to sport is roughly the same, but if anything, slightly higher in the OCA group, particularly the smaller ones. Return to sport is quicker in the OCA group compared to ACI. So return to high impact activities or potentially return to work is going to be higher in OCA, particularly manual worker. And the rehab shorter as well with OCA because, again, it's only 1 procedure. So the cost per quality actually is more beneficial towards OCA versus ACI, but it's difficult to put an actual number on it because there's been no comparative trial. So conclusions with that, osteochondral allograft is an excellent option, but will never be a universal solution, and that's principally due to availability as much as anything, and Christian will talk about that. There's a significant supply and demand problem, which is difficult, I think, to overcome unless we have a UK solution, but that is a long way off. In the meantime, I think if we want to rationalise the use of these products, then it should be restricted to need and not to indications. So very much those indications we've talked about, as opposed to just over 2 square centimetres. That requires sort of a bit of national framework, but again, that is a long way off. So lesions greater than 2 square centimetres in individuals have a guarded long-term prognosis, and intervention should be considered early following the onset of symptoms. The data would sort of suggest that is probably the better way to go, as opposed to leaving them until as long as possible. I think it's important to select the right therapy for the right lesion, and that needs to be done the first time. And so we really need to increase our ACI numbers. We're way below what it should be, and if we don't increase our ACI numbers, then again, I think Codon will follow, Tygenix, Macy, pull out the UK, and then we won't have an ACI option. And as a consequence, because of the restrictions, then I think we are at the stage where lesions should be treated with over 2 centimeters with advanced therapies in specialist centres, because that's where the ACI is being carried out. And I think we should be at least saying to patients, or offering patients, the option of having ACI or having their advanced therapy with a 2 centimeter lesion. And it's patient's choice. If they choose not to, then that's fine. But I think we need to be giving them the option to be shown that we're compliant with NICE guidance, and also giving them the best option for these lesions. Thank you.
That's great. Thank you, Professor Snow. We'll move on to the second part of the talks today with Christian Besnard from JRF Ortho.
Hello, greetings from Denver, Colorado. Thank you to Jim and the Joint Operations team. Thank you to Professor Snow. Really appreciate the opportunity to be here with you today, sharing a bit of information about our experience with osteochondral allografts. Thank you to everyone who's attending. I appreciate your attention. My name is Christian Besnard. I'm with JRF Ortho. JRF Ortho is a highly focused organization, highly specialized organization. We focus on the distribution of osteochondral and meniscal allografts. And although we're a small organization in terms of number of staff, we do supply roughly 60% of the osteochondral allografts to the US market. And specific to the UK, I've had the privilege of working with joint operations and many of the surgeons in the UK for multiple years now. It's really something that I enjoy a great deal. So thank you again for the opportunity to be here. As we start talking about this, just to give everyone a little bit of context for the situation with osteochondral allograft graft usage in the United States. We're in a bit of a golden age, really, and that has a lot to do with the confluence of multiple factors. More and more published long-term clinical outcomes data from surgeons like Dr. Bill Bugbee, Dr. Brian Cole, many others, married with improvements in surgical techniques and instrumentation to support these procedures. And then on the donation side, we've seen a continued increase in overall tissue donation numbers, and subsequently then the availability of these osteochondral grafts has improved in the US. This has led to a great deal of popularity and increased use of these grafts, but in many cases, supply is still the biggest hurdle. And in fact, globally, supply is really the rate limiting step. Specifically in the UK, surgeons need to contend with very limited supply from the US, as well as other hurdles like cost, regulatory differences, the logistics of a graft that has a very short shelf life, and lack of a current supply. We'll talk about that a little bit more in just a moment. So my goal for the next few minutes here is to talk a little bit about why these hurdles exist, and what we may be able to work on in the future to try to alleviate some of these issues and potentially make these grafts more available to surgeons in the UK and in other places. It all begins with donation, and I apologize. I don't want to be cavalier or seem crass with any of the language that I use today. We may discuss things in business terms, but really the organizations who are involved with these grafts in the US largely are nonprofit organizations. JRF Ortho is a nonprofit organization. So it is very much mission related, and it all begins with donation. We see ourselves as the bridge between donors and patients, and making sure that those wishes are fulfilled and those grafts can be safely utilized to improve lives for the patients. So in the US, there are roughly 30 to 35,000 musculoskeletal tissue donors every year. That represents about 100 per million in the US. Comparing to the UK, estimations would be only about 10 tissue donors per 1 million population in the UK. And that really just represents, a head start in the US to a certain extent in terms of educating the public about the power of donation. After donation occurs, the magic with osteochondral allografts really becomes an exercise in process efficiency. And what this amounts to is effectively and efficiently linking, in most cases, 4 to 5 highly specialized organizations who have some touch, some aspect of this process as the grafts move forward. And you need to be able to effectively and efficiently link the communications and the expertise of these organizations within very, very tight timeframes. So specific to osteochondral allografts, it again begins with donation. And in the United States, that education and consent component for donors or donor families, as well as the actual surgical recovery of the tissue, occurs with organ procurement organizations or recovery agencies. From there, the tissue goes on to processors like in the case of JRF Ortho, we are a joint venture, 50-50 co-owned by Allosource and Community Tissue Services, two of the largest and most reputable tissue banks in the world. Their responsibility then is to receive that donor tissue. And really, this is the engine behind a lot of what we do. The processing occurs here, medical chart review, serological testing, microbiological testing, everything really here in terms of the safety component as well as processing is taking place with these tissue banks. JRF Ortho, we play the customer-facing role in most cases in terms of receiving the requests, sizing and matching, and then allocating the appropriate grafts. And then in specific to the UK, we rely heavily on joint operations to not only be able to receive and handle these grafts appropriately to safeguard ultimately the surgeons and their patients, but also supply the day-to-day support, the surgical instrumentation, basically all of the customer-facing components for the surgeons there in the UK. And all of this needs to occur, again, within very, very tight time frames. For JRF Ortho, based on validated testing of the chondrocyte viabilities, these grafts expire at day 28 after donor death. In most cases, the longest part of the process in terms of donor clearance are the 14-day microbiological results. So within this 28 days, best case scenario, any particular donor will be released by the medical director at roughly day 15 or day 16. Concurrently during that time, that's when you're seeing the actual processing of the tissue. The serology results are being completed and verified. The medical chart review is occurring. All of that is happening. And in most cases, you're waiting for those 14-day microbiological results to come in then the medical director can release the donor for distribution. But again, that's day 15 or 16. So in most cases, you're looking at roughly 2 weeks to coordinate the shipping, the logistics, the patient, the theater time, in order to make these cases happen. So again, the logistics can be very, very daunting, very, very difficult with these grafts. Added to which, when we're discussing potential international request, the pool from which we can find matches and ultimately offer grafts is fairly substantially smaller than our overall donor pool. And that has to do with making sure that that donor has been consented to potentially be distributed internationally. The sizing, of course, is appropriate to the individual request. And then the biggest factor has to do with some differences in donor eligibility criteria in various international markets. And so UK specifically, again, there are some differences between what the HTA requires and what the US FDA and AATB require. And so the note here is that our 100% in terms of the number of donors and donor grafts available to us in our pool, ultimately what we can choose from and potentially send to the UK is more along the lines of 20% of that overall donor pool. So what could be done in the future to potentially alleviate some of these issues and make osteochondral allografts more available to surgeons in the UK? I think it's very important that there's continued collaboration between surgeons, industry, regulators. A good example of this is the European Allograft Initiative that Professor Snow is a part of, Tim Spalding, Peter Verdonk. These efforts included things like health economic studies to show that the upfront cost of these grafts ultimately does, there is a positive impact to the healthcare system long term in terms of what can be done for the patients despite the upfront cost. And then helping define for regulators what the clinical demand really is. What does the demand picture look like? In other words, how large is the potentially underserved population with this? Within that dialogue with regulators, if there's a possibility in the future to potentially normalize donor criteria specifically between the US and the UK, that would open up a tremendous amount of tissue to potential distribution in the UK. There's a lot of science going on in various locations around the world to take a look at prolonged graft storage, which would greatly ease the logistics around these grafts. If you could extend for a few weeks, even longer, and still protect the safety and viability of the grafts, that would certainly help in placing these tissues in other countries and markets around the world. And ultimately, working on developing a local UK supply, and where there's opportunity to potentially partner, JRF Ortho would be very excited about taking a look at that. Is there a way to make sure that local UK tissue donors can be used to better serve UK surgeons and ultimately UK patients? So key takeaways from this is that osteochondral allografts have an established and critical role in the treatment algorithm, but supply is a rate limiting step. The addition of an international request now when you're talking about US supply is another fairly large hurdle to try to get over. As a surgeon, if you believe that you would like to incorporate this into your treatment algorithm, understand that the timing is very difficult, the logistics are very daunting, and not only you, but your patients, your staff, your facilities also need to be educated on how to navigate that process. And ultimately, again, if there's opportunity for partnership and to take a look at creating a more local supply of osteochondral allografts in the UK, I think that will better serve the surgical community and the patients in the UK over the long term. Thank you. Look forward to the question and answer session. Thank you again, Jim.
Fantastic. Thank you, Christian. That was great. The question and answer session will be after our final talk, which is back to Professor Snow for cartilage lesions that are less than 2 centimeters.
Okay, so going to move on to treatment of lesions less than 2 square centimeters. Now, this is a much more controversial area. And so I'm really going to sort of just go through some of the generic treatments that we all know, and then the others then are really much going to be based on my experience, some of the work that I've done as a bit part scientist, and yeah, some of the ones that I've implanted. So again, just to reiterate, it's really important, meniscus alignment stability, and that cannot be I still see a lot of people that haven't taken that into account. So this is a cartilage repair algorithm that could be picked out of most books, I'd say, but you can see the issue. So I think most people are now using 2 square centimeters as the cutoff, and so you can see if you don't have ACI, so that's taken out of that section because NICE has said we can't do that. And then with the 2 centimeters, as we've said, ACI, fresh allograft, they're out. So that's really what it looks like if you're at less than 2 square centimeters. So I've left that augmented repair. I'm sort of putting microfracture EMIC into augmented repair, and we'll come on to that. And you still need an option for that. And that's because some people don't want ACI. So people don't want to go through a 2-stage procedure. And actually, with the codon product, 1 in 10 of the ACIs will fail the manufacture process. You need an option for them. So you may still have to treat lesions greater than 2 centimeters with an augmented repair of some sort. So first of all, microfracture, so I'm not going to dwell on this too long, just pick up the bits. So the alls result in bone compaction. So there's been some good animal work by guys in Canada which have looked at in rabbits principally, but because of this compaction, the alls block vascular channels, and then that reduces the release of the bone marrow from underneath, and therefore reduces clot formation. It also causes 20% versus 8 or 9% if you use a drill, and therefore there's a bit of a move away really from alls, and the evidence again from animals, not from humans, would suggest that a nanofracture would be potentially the way forward. So drilling smaller and deeper, so 1 to 2 millimeters, 9 millimeters deep, and that's been shown in animal work to try and release the bone marrow elements, and it does that much better than an all. And I just want to mention at this point, I still see this a lot, and it has implications now for ACI. So microfracture, the whole concept is based on an intact subchondral layer. And I still see a lot of people that have been referred following OCDs, and they've microfractured the base. Now, the problem with that, A, microfracture is not going to work because it needs a subchondral layer, and B, the problem then comes is if you've done a microfracture, then I can no longer do an ACI, because some people may interpret that as a attempted repair. So it's important not to microfracture OCD because it does need that subchondral layer. So the issue with microfracture is that it is scientifically flawed. So the properties of the clot induced by microfracture are not conducive to healing back to normal hyaline cartilage in a large part, and that's due to the limited scaffolding of which marrow-derived cells can attach, and that's what Richter said. And essentially it's because we have a low concentration of stem cells from the microfracture compared to the defect size. So only 0.01 to 0.001% of all mononuclear cells are MSCs in the subchondral layer. And on top of that, there seems to be an anatomical variation. Again, in animals, they've shown that the ability or the potential of those cells to induce repair are worse in the trochlea as opposed to the femoral condyles. So there's anatomical variations, and that's maybe why microfracture of the trochlea doesn't do so well. And if we look at what's actually produced in humans based on biopsy, Knudsen, he compared the results to ACI, and he said that predominant repair tissue in his biopsy fiber cartilage, 20% of the biopsy specimens were inadequate or showed no repair tissue at all and was just bone, and 51% of the defects were filled with fibrous tissue, which we know is of poor durability. And then the issue is the effects of the bone itself. So Mithoff has shown with 84 patients that subchondral bone overgrowth, these interlesional osteophytes, are present 62% of patients, and 93% of patients who failed microfracture were found to have these intralesional osteophytes and overgrowth. And that was statistically significant. And we also know that in these patients as well, that if you had less than 2 centimeter lesion, then you had a much better chance of returning back to activity. The other thing which is not really discussed commonly is that our ability to do microfracture consistently is pretty poor. So in this, they assessed 4 surgeons, asked them to perform microfracture, and then they analysed with CT and also histology. And what they showed is that all 4 surgeons were not particularly good, and they misjudged the whole distance and the holes too deep and too close together with the awls. As a result, they got whole coalition. Their ability to create those vertical walls wasn't very good either. And in a lot of cases where the calcified cartilage layer was not removed, and therefore whatever regenerate is there, it's not going to stick down. So, we need to be better and pay much more attention if we are going to microfracture or nanofracture to our technique. And like I said, just to reiterate, it's important not to sort of do microfracture inappropriately in patients like an OCD, just because not only does it have an effect on subsequent treatment, it actually, under our working restrictions, prevents us from doing that treatment. So NICE won't let us do an ACI if we've done a microfracture already. And if you do a microfracture, then it's 3 times higher failure rate. It's not that ACI doesn't work, it's just because there's a 3 times higher failure rate, it no longer is cost effective. So then next is OATS. So in the case of OATS, so grade 3-4 lesions, tibia and patella, controversially so. I've never done patella, but I have done tibia, we'll mention that. Up to 1 to 2 centimeters. For me, it's a 1 centimeter lesion, but yeah, we can discuss that. Osteochondral defects, but can do it for isolated chondral defects. So lesions with subchondral edema, or you're concerned about the bone underneath and failed microfracture, again, on the same principle, osteochondral allograft, this is effective. So in terms of harvest sites, so should be chosen based on the size. So 6 millimeters around the notch, 8 millimeters then can be chosen in the sort of trochlear region, and then the right at the top of the flare is where you get your 10 millimeter grafts. So should stay away from the larger size graft close to the sulcus terminalis. So for me, medially is my preferred, just because generally most people laterally track, so it makes a bit more sense to go medially right up the flare. So the advantage, single stage procedure, rapid bone to bone healing, although the cartilage never heals to the side. It's obviously restoration of hyaline cartilage to the thicker surface. It's relatively cheap, and it obviously addresses bone problems. But obviously donor site morbidity is the main issue. So for me, it's 1 plug, 10 millimeter plug. I might be stretched to go 2 potentially, but it would be a rare occasion. If you do multiple plugs and take more to get those stable, and it's difficult to replicate the normal curvature. Obviously, the bigger you go and the more plugs you use, so you need to be a little bit careful of that. So this is a paper that reports the results in the patella, 33 patients. It's not something that I've done, but they reported reasonable results at 2 years, showing good MRI pictures. What I have done and can be useful is retrograde OATS, so in tibial lesions, so areas of failed microfracture or traumatic OCDs, you need the specialist instrumentation to allow you to drill up from underneath, assess the obliquity of your plug and insert. And yeah, there's not many cases in the literature, and this is probably some sort of my experience as well, probably about 4 or 5 lesions, but they seem to do okay, and they incorporate the results would support that for these difficult lesions with not much options left or open to you, then a retrograde oats can be considered. So if we actually compare these two sort of old school procedures, you know, microfracture versus oats, so it would actually appear that oats is the better option. So in these sort of long-term studies, that with a median size of 3 centimeters, so bigger than what we're talking about, but from 6 months to 15 years in this study, oats was better than microfracture in terms of lifetime scores. Then at 15 years, there was no difference. They both deteriorated. So, and the other thing that you consistently see with papers of oats versus microfracture is the better activity levels. So in these 60 athletes randomized to oats or microfracture, there's better outcomes in the oats group, particularly in terms of activity. So 75% in the oats group and versus 37% in the microfracture group return to the same activity, with only 4 failures in the oats group versus 11. So in that in the microfracture group, so then that higher activity bracket, then oats is much more durable. So this is the main sort of area really of controversy, really, is augmented repair. So I've classified a few treatments in here, but I'm actually a fan of augmented repair because principally, if anything, it makes people think twice about treating incidental lesions without screening, particularly alignment. I think this is a big mistake. If you find a lesion, no matter how big it is, if you have not screened that patient for a cartilage treatment, then the best thing to do is nothing. And you can turn an asymptomatic lesion into a symptomatic one, or you can result in early failure because you think their legs are straight, but if you do an alignment film, they're actually not, and the mechanical axis is in the weight bearing, and that lesion is then doomed to fail. So augmented repair often needs some equipment, and therefore can't be done there and then. So that's not a bad thing. It takes time to step back. I think the issue with augmented repair is that there will always be a limitation in the literature because what we've discussed, these are lower cost items. It's very expensive to do the studies, and therefore there is this reluctance on behalf of the companies to invest that amount of cash. I think there is enough evidence for me between clinical studies, basic science, to show that it's superior to microfracture. And like I said, we still need an augmented repair for the larger lesions in people who refuse ACI or people where the ACI fails release. So like I said, that's 1 in 10, which is not that uncommon. So augmented repair requires a scaffold of some sort that can either be done in conjunction with a microfracture, in which case it's then called AMIC, or it can be done in conjunction with bone marrow concentrate. And that's plus or minus microfracture. So there's different types of scaffold, and I don't think there's any data to suggest one is massively better than the others, and that's principally because the data is not there on all of them. The main scaffolds that I've been involved in, and the ones that main data is collagen, which is guide, and then chitosan, which would be BST Gargel, and hyaluronic acid, which would be Hyalofast. And there's been a review article in the AJSM. So Henin Madri, he had a look at all the data and said that it was 28 clinical studies, 12 studies were admitted as part of the review with 245 patients. And he concluded that it was a paucity of high quality randomized control studies testing AMEC technique versus established techniques such as microfracture or ACI, and so couldn't really make much conclusions. But like I said, there are a couple of more established scaffolds. So chondroguide would be one. So chondroguide, so it's important to know your scaffold and how it works. So for chondroguide, it's porous underneath, and then the porosity reduces higher up, so it forms sort of a barrier. So it's a sponge underneath and a barrier above. So it's good for an AMIC type procedure because it'll absorb the clot and then prevent clot loss by sealing it off at the top. If you use it though with BMAC, then it's not going to work as a sponge. So you're better off activating the clot and putting the chondroguide over the top as a cover, and then obviously fibrin glue to seal it completely. So it's important to know how these scaffolds work, and as we go along, I'll mention them. But so, like I said, good for AMIC, but if you're going to use BMAC, it's not going to soak in it. You need to activate it, form a solid, and then seal it off with the chondroguide. And so one is this one in terms of RCT of AMIC versus microfracture at 5 years, so 47 patients. So I think power is a little bit low for me, but it's probably more powerful because it's gone out to 5 years. They did show a difference, so everyone was the same at 2 years, but at 5 years, the AMIC was better than the microfracture group, both in terms clinically, but also in terms of imaging. So that's evidence for the chondroguide. And then this is interesting, and it'll be interesting moving forward. So Gunnar Snow, we talked about earlier, but with regards to the microfracture, big in the ACI world, he's just randomized AMIC to ACI using the chondroguide. And again, we've sort of said that at the minute there's no difference between the two groups because we're out to 2 years, but interestingly, they already had 2 failures in the AMIC group. So it sort of reinforces that probably, augmented repair, again, still should be potentially kept below 2 centimeters, but yeah, it would be interesting to see what his longer term data is. The next scaffold would be and the next best evidence really is the Cartilage. So they took an 80 patient study. So at this point, it wasn't powered for clinical symptoms and was mainly powered for histology. But so that's what they say with 80 patients. So what they found was actually there was no difference in the clinical outcomes at 12 months, which is, again, probably a little bit early, but there was superior histology interpreted by MRI fill and T2 relaxation times. And that was maintained out to 5 years. They were still better on MRI in terms of fill and signal, but again, there was no difference clinically at 5 years. They did do these biopsies were much better in the BST Cartilage group, showing better surface architecture, viability, cell distribution, and collagen organization. So on the basis that you get better histology, you will get a better durability or long-term results. So that, again, there's that slight lack of evidence with regards to clinical outcome. So bone marrow concentrate. So the evidence for this, again, is a bit limited, but there is some interesting evidence in the animal world. So this would be the best. So a mini pig study looking at a 6 millimeter defect of BMAC versus actual stem cells, so MSCs. And both treatments showed significantly improved repair, but there was no actual difference whether you used a minimally manipulated MSC or a expanded MSC. So suggesting that if you have enough minimally manipulated MSCs, you could induce a repair. So if you're going to go down this line, you need to make 2 decisions. Decision 1 is how to generate BMAC, and you either go down the marrow solution route, where you use this trocar and the special introducer in the middle there will preferentially remove the marrow as opposed to the venous contamination, or you go down at much larger volumes and put it through a centrifuge such as the Harvest. And these are probably the 2 most common products I've used. From the data that we have, it's pretty limited, but from the data that the company for Spice as well, and we did seem to agree with that, is that if you only need 2 mils, then the numbers of colony forming units are roughly the same with the Aspire needle as with the Harvest system. But if you need more than 2 mils, then you'd be better off going down the centrifuge route. But for the majority of lesions, you don't need more than 2 mils. So this is a quicker, easier, cheaper method of obtaining roughly the same number of cells. And then you've got to make a decision in terms of which scaffold to use. So we've already discussed a couple of them. So chondroguide, we've discussed Cartilage, and then the third most common scaffold is Hyalofast hyalofast. So these all work in 3 different ways. So and these are decisions you make. So hyalofast is very much a sponge, so that would soak up bone marrow, but then doesn't really have the barrier to stop it, the cells leaving. So that definitely needs fibrin glue to try and seal that. The chondroguide, like we said, we need to activate because that's more of a barrier, and you put that over the top and then seal it. And then the Cargel, that's a gel. So that has the advantages of trapping the cells within it, but then the disadvantages of the fact that it's not that structural, and therefore for uncontained defects, it's not possible. It's not indicated. So it has application limitations. So it's about selecting the right treatment for the right lesion. And we did some work in terms of scaffold, and we looked at viability, and we looked at chondroguide, hyalofast, and chondroshield, and we looked at how many cells we could get on this. Interestingly, chondroguide actually had the most number of cells on it, despite it having the least porosity. But what we realized is that the overall cell number wasn't as big as we thought it would be. There's not that many green dots at 1 day, 7 days, 14 days, 28 days. So that's why we started to look at other options. But Alberto Gobi's probably done the most, or has the most literature in terms of the use of BMAC. He's done it in different ways. So again, he's done a 25 patient study, older patients, larger lesions, so more degenerate. So in this one, he's activated there, like he has in the picture, turned it into a clot, and then put the chondroguide over the top. And he said that in patients under 45 with single lesions, small lesions, showed greater improvement, and they had hyaline-like histology. So for small lesions, this would appear to be an option. And he's also done the same study, but using the hyalofast, so hyaluronic acid, and again, produced very similar results. And in this one, he did compare it with microfracture, and he showed that the KDC was 100% normal in BMAC versus 64% in the microfracture group at 2 years. And then it's similarly, the microfracture group continued to decline after 5 years to 28% normal patients, where the BMAC seemed to maintain, had better durability. So again, augmented repair seems to be better than microfracture alone. We looked at, in this study, we looked at, could we introduce bone marrow into Cargel? So normally Cargel would be mixed with blood. You would do a microfracture and then insert the Cargel, and then it clots off, and this is the normal sort of histology of the specimens. And we've tried to repeat that, but instead of using blood, using bone marrow concentrate, actually using the harvest and then the Aspire needles, so using both those systems. And we were able to show that we were able to achieve better cell viability, but that sort of came at a cost. So the clots were not as solid as they are with the normal. So it's a trade-off of maintaining better cell retention, but slightly worse physical properties. But we were able to maintain good viability out to 7 years, and we've published that in Journal of Cartilage. So if anyone's interested in that. So if we try to sum that up, the role of bone marrow concentrate, so there's this systematic review published last year, 10 animal studies, 13 clinical studies. Animal studies showed inconsistent outcomes. The clinical studies reported improved clinical outcomes and higher macroscopic MRI and histology scores. Comparative trials favored BMAC over microfracture and reported equivalent outcomes between BMAC and ACI. Interesting to note, like 60% of the world's literature is produced by Alberto Gobi, so there is this potential for some bias there. But overall, they concluded that clinical studies were scant and showed low scientific rigor, poor methodological quality, and low levels of evidence on average. So the data is a little bit sketchy. So primary chondrocytes, I just want to mention this. So this is another study I was involved with. So it's now called CAR-T1. It was called Struck when we were involved, but this is the principle of core culture. So mixing primary chondrocytes, so taking a biopsy like you would for ACI, digesting it, extracting off the chondrocytes, and then taking a bone marrow aspirate, again, removing the mononucleated cells and combining the two in a treatment with a specific ratio. It's usually like 2% chronocytes minimum, and then mixed with the mononucleate cells. And in the study, the Instruct study, we used this scaffold called Polyfit, which is a polymer cement restrictor originally, but it did mean we had to penetrate the subchondral bone, which was really a weak point in the study. But interestingly, it's called Carty1 now, but if you type in Carty1 to the internet, be careful, because you'll get a picture of Playboy Carty with his album One Day. So yeah, it's different if you're looking for the instructions for use. So participating surgeons, it was me, Peter Badonk and Konrad in Poland, and we usual inclusion criteria, basically we were confined to less than 1.8 centimeter lesions, because that was the bigger size of the scaffold, and we showed some good results in terms of Kuh's patients improved, and the MRI. So this would be a classic example. So this was 2 weeks post-op on the left, progressing through to 2 years with good bone resorption and good fill. Like I said, not all of them look like that, and I think that is principally due to the scaffold, because what was quite impressive is that when we looked at histology, 71% of the specimens did show hyaline cartilage or hyaline-like cartilage. So I think it showed that the cell combination worked, and that's just been published now, literally like this month in AJSM. But you can now do that cell combination in one of the established scaffolds that we've already discussed, so a Hyalofast or a chondroguide. So, which I think would be a significant improvement then from the osteochondral scaffold that we used in the study. And then lastly, just mentioned osteochondral allograft. So again, there is that potential in this population. There are pre-made 16 millimeter osteochondral cores. That's equivalent to 2 square centimeters. If we're using plugs of less than 20 mil diameter, then size isn't so important, because once you get down to that small, the radius of curvature differences are not significant. So as a consequence, then there's no issues around weighting, no issues around availability. These are freely available, and I think if we can sort out the finances, this is a good option for those sort of smaller lesions. So in conclusion, I think the important thing is to say, definitely do not treat these lesions unless there's been a full assessment of alignment meniscus stability. It's still the most common mistake made. So for me, so microfracture, I only do that now. Small lesions, if I'm doing multiple surgeries, so I don't know, transplant, ACL plus a cartilage treatment, just with it, again, a lot of that is due to time and complexity issues. And ideally, yeah, it should be a nanofracture. And there's various commercially available products, or wire, or sometimes instability shoulder drills are a good option as well. OATS, I generally do 1 10 millimeter plug, and I'll prefer that to microfracture in a higher demand, or if there's a bone lesion, or like I say, it's a revision lesion. Augmented repair, in my view, is probably better than microfracture, particularly in more difficult lesions. And my preference is to use BMAC without the microfracture, so you're potentially getting the benefits without the downsides of the bone damage. So potentially you're not, if and when it breaks down, there's still options available. You're not burning too many bridges, but ultimately just what works for you. And just I'm on the trial steering committee for seismic. So so Nick Howells is undertaking microfracture versus AMIC study out of Bristol. So if anybody's interested, you should contact him. Thank you.
That's great. Thanks very much, Martyn and Christian. We'll just wait to see that the guys come back up. There's Martyn. Hi, Martyn.
Hello.
Hi. Just wait to get Christian back up. And there we are. Hi, Christian.
Hi, Jim. Hi, Professor
Hey,
Snow.
thanks for that. That was great. We've got a few questions that have come in. I'll start off with one here for you, Martyn. Questions on a lightning bolt type shape defect. To put an osteochondral allograft in that type of defect, you sacrifice good, healthy cartilage to capture the whole defect. What tolerance do you have of how much healthy cartilage you would take either side, and would you combine another technique in the same sitting to treat the whole lesion?
What was the first part, Jim? The very first
If you've
part?
got a lightning bolt shape type defect, how much
like
of the healthy
longitudinal one?
you would sacrifice to put in an osteochondral allograft?
Yeah. Okay. Yeah, it really depends on the size. Yeah, obviously on these allograft sets, you have various dowels that can template and allow you to make that decision. Obviously, if you've got to the point where you've got an osteochondral allograft in front of you, you're going to use it. And that is by far the best thing that you can do. So you wouldn't combine it with any other option. So it would just be a case of decision that if it was very specifically longitudinal, and I wasn't happy about creating or taking a lot of normal cartilage away, then I could make a hand shape a defect to sort of a hand shape handmade sort of shell type. But in reality, that you don't tend, if you're, by the time you finish your debridement, you're not actually destroying that much associated cartilage. So, but yeah, the option in that scenario would to hand shape a shell type graft.
Okay, great. Thanks for that. Another question for yourself around ACI service. Someone asked if I'm considering establishing a chronosphere ACI service in my hospital. There is dependent on financial mitigation for the scenario in which the implantation cannot proceed due to patient illness or similar avoidable reason. Is there a provision for this from NHS England?
No. So the issue is that that's just part and parcel of the procedures, one of the downfalls of ACI. So, like I said, 1 in 10 ACIs won't be released by the manufacturer. In that scenario, though, they don't charge you for that. Sometimes you can negotiate. They're very strict these days in terms, because it's now ACI is now treated as a drug, a pharmacological product. So it has to be delivered in a very specific way. Previously, what they would do would freeze the cells for you if there was an emergency, like the patient had a wound infection or they were unwell. But essentially, thankfully, it doesn't happen very often. It can be delayed a couple of days later, or in the emergency, so they may let you freeze, but in the current guidelines, no. But that's just nature of it. I think you'd get one option at it, and if it failed, then that would be it. There's no sort of provision for a failed implantation. You still have to pay the company for the service if it's a patient problem.
Okay, cool. Thanks for that. Christian, question here for you on osteochondral allograft provisions. Obviously, looking at the current situation, how in a pandemic situation like we're in now, does that affect the availability and the process that the grafts might have to go through?
Yeah, it's a great question, and frankly, we're learning more and more about that every day. We actually completely discontinued processing of grafts in the middle of March, simply because the time frames associated with these grafts are so short. We were fairly certain that any donor tissue that we would process would ultimately go to waste, and that just doesn't fit with the mission. There are other graft types that those donors could be used for that have longer shelf lives, so to speak. So it wasn't a responsible use of the tissue. as we're getting back to processing now and looking to place tissue, there are additional screening guidelines in for COVID-19. So those have come from the FDA and the American Association of Tissue Banks. So that's part of the screening process. And they're still looking at validating a serology test. This would be a nucleic acid test. But as far as I'm aware, that has been submitted to the FDA for approval, has not been validated and approved yet. So there are some recovery agencies that are using the nasal swabs as part of the donor screening process, again, to see if there's any evidence of live virus. And as we get back to processing, we're trying to wrap our heads around what the impact might be for the donor pools, the donor population. We think it's fairly minimal. This is just it's a bit of a process of starting the flywheel again, right? We have been running with a great deal of efficiency. When you stop things and then you start to you try to turn them back on, sometimes you lose a bit of that efficiency in the short term. So.
You still there, Jim?
I bored him already. I put him to sleep.
Wait, he fell asleep mid-answer. Does that, in that respect, Christian, does that just apply to the fresh allograft? You're still collecting tissue for frozen, yeah? So you're still collecting meniscus and stuff.
Right. So the community tissue service and allosorts that I spoke about in my section, they're still receiving those donors, and they would make different decisions regarding what to do with the donated tissue. And so, as you're saying, meniscal allografts, tendons, bone grafts, whether they're lyophilized or frozen, then have a much longer window for implantation. And so those could still be received, processed, and then still fits within the mission that we know we have a good opportunity to place those. The fresh grafts are an anomaly in that regard.
Yeah. And is there any plans to maybe increase the pre-made grafts sizes?
We just had a webinar the other day with Riley Williams from HSS, and that was one of the comments that he made. The data from our own internal data would suggest that the average plug that's ultimately implanted is closer to 20 millimeters in diameter. And so working toward, getting to those types of sizes is something that, yeah, we're taking a look at. It ultimately amounts to, putting the procedures in place, obviously making sure that we're using the cartilage, the donated tissue that comes in appropriately, and as well doing the training, because you have technicians and not trained orthopedic surgeons cutting those plugs. So as we get bigger, we just want to make sure that all those things are accounted for, so that those plugs are appropriately fashioned for you to use in theater.
I suppose
Martyn,
really,
I don't know if you can hear me. It's David Penfold from Clockwork Medical. We've lost poor connection, but I do have some questions, if you don't mind me fielding those.
Go.
One question that's been sent through is, what is the deepest defect you can do with AMIC?
Yeah, so I think with any sort of chondral treatment, there's no absolute number really, I suppose, in terms of how much bone loss you can accept. But what I generally do, it's really about how much bone loss is it worth or practically able to bone graft. So most people would say somewhere around sort of 2 to 3 sort of millimeters. But if you because otherwise then it's not worth the bone graft. So or it's technically difficult to keep the bone graft in place. Usually what we do, take some bone graft, mix it with some fibrin glue so it's a little bit sticky, and then impact it in place. But I think the thing about AMIC is the issue is, again, it's AMIC with microfracture is based on the fact that subchondral bone needs to be intact. So yeah, in that scenario for me, I usually actually just bone graft if there is, and then pre-ACI days we would then put in bone marrow concentrate, either activated over a chondral guide or soaked it Hyalofast, and then fibrin glue over the top. So you'd go bone graft mixed fibrin glue, pack that in, fibrin glue sealer, then the bone marrow concentrate, and then with whatever scaffold you're using, and then fibrin glue over the top.
Great, thank you. A question to Christian, actually. Are measures in place generally to increase the eligible donor pool?
Yeah, there are. I think that's always one of the goals of, in the United States, there's an organization called Donate Life that is, again, a nonprofit organization that really functions to educate the public about the impact. Organ donation, typically people are a bit more aware of. Tissue donation, there are often still gaps in the general public's understanding. So that's always something ahead of us to work on. The challenge with the osteochondral allografts is that based on viability, health of the cartilage, we are actually working with a fairly small subset of the overall donor population to begin with. So we're looking at, maybe 10% of the overall donor pool. But as the overall donor pool increases, then we get a bit of a bit more of the younger donor population that we tend to filter for the cartilage grafts. And so again, I think there's opportunity for growth in that regard. Specific to the UK and some other markets, I think it goes back to what both Professor Snow and I talked about, is potentially some discussions around regulations, and is there an opportunity to normalize those a little bit between the two countries. And then ultimately a local UK supply would probably have the biggest impact for UK surgeons.
Right, thank you. A couple more questions. One more to Martyn. Nanofix, does it have specific instrumentation?
Manufacturer, no. So yeah, there are commercial available sets available. That obviously comes at an expense. Otherwise, low-cost tips, you can either use a K-wire, but the only problem with that's a little bit blunt. It could generate a bit of heat. The best tip is that if you're a knee surgeon, then you see what shoulder anchors you have in the hospital, and there are some commercially available curved instability drills, and they can go down as 1.6 mil or up to 2 mil, and they're actually nice and curved. So you can drill down the guide and you can get perpendicular to the defect. So they are my actual go-to because they're often on the shelf and they are free, except for obviously the cost of sterilization. So that's the best option. So see what you have on the shelf in terms of the shoulder stuff. But otherwise, K-wire or a small drill.
Okay.
The only problem with the small drill is difficult arthroscopically because it can snap.
Right. Just one more question, really, to Martyn, if I may. What is the tolerance of depth of deficit with OCs?
Yeah, so there's the thing about the osteochondral allograft is that the marrow or the bone is where the marrow elements is from the donor. So potentially, if there's going to be some element of rejection or low-grade inflammation, it's going to be as a reaction to what's in that marrow. So you try and wash it out as best you can, but there's still going to be some residual sort of DNA probably from the donor. So you want to keep it to a minimum. And although if you go, there's been some recent work to show that if you actually go thinner, that can relate to some cyst issues as well. So it's usually about 3 to 5 is probably where most people aim. Like, so you can go up to 10, but then you run the risk of a greater reaction and potentially a non-union. So that's the sort of range you're looking for. Like I said, sometimes it depends. Like, so that AVN case, there was obviously a lot more bone to replace, but you wouldn't go below 10. You'd actually take some autologous and pack that in and then put the 10 max if you want to go down that route. But 3 to 5 ideally, but maximum 10. But that would be with a plug. I wouldn't do a large structural sort of shell allograft with a 10. Otherwise, again, if that doesn't unite, then there's quite a lot of bone stock missing.
Thank you. And final question, actually, to both of you. The sizing and matching of OC grafts, what's the process from surgeon to JRF and back to surgeon? If I could start with Christian, please.
Yeah, I think we have the process down with many of the facilities in the UK to a fairly normalized type of deal where the patient imaging, whether that's X-ray, MRI, CT, we can really measure off whatever's available. Depending on the security measures at the hospital, that can be uploaded directly. We have a secure online ordering system where the films can be uploaded. If they can't be for security measures, joint operations can pick up the discs and actually ship them to us. Our customer service folks then measure based on that and activate the request. The difficulty, as Professor Snow is talking about, that gets activated for graft type, and then based on really this is a match in terms of bony anatomy, right? So we can match in some cases based on the size of the lesion, but we're not trained radiologists. We're obviously not surgeons, and so for the most part, we're matching bony anatomy from donor to patient. The difficult thing is that goes in the system and is activated. Then, as Professor Snow said, you're in a waiting game, and then all of a sudden you get an email one day saying we have a graft. You have 10 days. You have 2 weeks to sort everything out in terms of theater time, patient being available, and that's the difficulty in the process.
Yeah, so I think GDPR has made things a little bit more difficult. So for us now, unless we took the imaging film, then we do not own that film, and therefore we can no longer send that along the IEP to the company. So in that scenario, we either have to get the originating hospital to send them, or we take a repeat film. So we'll take a plain X-ray apiolateral with a sizing marker on that for the magnification, and then that goes off. So that has made things a little bit more difficult. And then just from the practical perspective, then we're pretty reliant on these guys matching us for us. They're good at it, so it's usually spot on. Although there's still some variation that is difficult to take into account. I think you just need to deal with what you got. But and then so Christian said they'll phone up and you've got like given an expiration date. You then have to phone the patient. You say, are you well? Are you in the country? Can you? You have to find an operating date. Say, look, we're provisionally planning for this. Can you attend? And if they say yes, then you can accept and then you go. But yeah, this is very much not an elective procedure.
Right. Thank you. Well, thank you very much indeed to both of you for your time and efforts. It's been very, very much appreciated. And well, we look forward to hopefully seeing you again in a future webinar. But thank you very much, gentlemen. It's been much appreciated.
Great.
Thank you.
Thank you.
Bye-bye.
Cheers. Bye.